Okay, good afternoon. Let's go ahead and get started. So you guys have gotten my emails. I gave you your scores for your last two quizzes. I got all your homework. Thank you for turning them in. A little concerned on quiz number 4. I guess it was a challenge for a lot of you. Not for one individual. We did get 100% on one of them, but which means that that person was, the information that was on that quiz was in the material that was to be studied. So, and that's how I gauge how you guys are studying. That's why when Xavier gives you the when Xavier gives you the quizzes, I could easily have him correct the quizzes, but I don't want to do that. I want to see how you do firsthand by correcting them. So let's go over the quizzes real quickly before I start on the lecture. And ask questions as I go along. So quiz 3. So most of you got the lifespan of red blood cells, 120 days. That was pretty easy. Red cells die when the system consumed by the reticular endothelial system. This one was interesting. Adult hemoglobin molecule has 2 alpha and 2 beta chains. Okay, 2 alpha and 2 beta chains. Later on, when I asked for fetal hemoglobin, I got the same answer, 2 alpha, 2 beta chains. It's 2 alpha and 2 gamma chains. Fetal hemoglobin is 2 alpha, 2 gamma chains. And iron is stored as ferritin, not transferrin. Whenever you see iron storage, it's ferritin. Number 6, the molecule that binds with hemoglobin 200 times greater than oxygen is carbon monoxide. Most of you got that. The most predominant hemoglobin in adults is hemoglobin A. I did get a hemoglobin F. Number 8, extramedullary hematopoiesis. The extramedullary hematopoiesis sites are spleen, thymus, lymph nodes, and liver. And so make sure when you read these questions that you see the word except. Look for words like except, and then don't just go jumping into the answers. If you see words like circle all that apply, almost always, I'll say always, there's more than one answer. If you see circle all that apply, that means there's going to be more than one answer. Okay, what protein transports iron to the erythroid marrow? I did get a ferritin. Just remember, transport, transferrin, transport, and transferrin. And as most of you got this one, as ferritin accumulates within the RE system, protein aggregates are formed as hemosiderin. So most of you did pretty good on quiz number 3. Okay, quiz number 4. 1 and 2, almost all of you got the correct answer. Given a hemoglobin of 12, what's the approximate hematocrit? And rule of threes, 12 times 3 is 36. Okay, then going backwards, if you have a hematocrit of 48, what is the approximate hemoglobin? Again, rule of threes, the answer is 48 divided by 3, or 16. Number 3, people have trouble with. I think some of them, a lot of you had trouble with. 3 out of 12 is not 30%. So the way you calculate this is you take the packed cell volume, which is 0.3. That's the amount of red cells. And the hematocrit is defined as the amount of packed red cells in a given amount of whole blood. Okay, so it's 0.3 divided by 1.2, or 0.25. Okay, not 0.3, not 1, or whatever. Okay, so 0.3 divided by 1.2 is equal to 0.25. I guess
I was confused on that because it says that the hematocrit tube contains 1.2 mils. So wouldn't, like, if you're asking how much is the hematocrit, isn't it 1.2?
That's your total amount of blood in the hematocrit tube. Okay, so that's your total. And then so you measure the packed cells, which is 0.3 mLs. So by definition, hematocrit is a relationship of 0.3 mLs over 1.2. It's a percentage. It's a percentage of red cells in a sample of blood. So 0.3 divided by 1.2 is 0.25. I guess those of you, and I'll have to go back, if you round it up to 0.3, then I may give you credit for that. Is that what some of you did? Anybody? I'll have to take a look at it. If you put 0.3, then I may give you credit. Okay. Patient diagnosed with vitamin B12 deficiency. So in my discussions, I did talk about vitamin B12 deficiency as one of the ways to identify it is to look at the MCV, because it's a megaloblastic anemia, meaning that the MCV is high. So low, normal of high MCV, the answer is high. A lot of you put low. When I talked about, I'm pretty sure that when I talked about vitamin B12, it's a megaloblastic anemia, which means it has red blood cells. And I reference my answers too, if you can look at slide 4, number 19. I mean, lecture 4, number 19. And I talked about iron deficiency anemia quite a bit as well. And it's an anemia. A lot of the red cell parameters are low, but there are two parameters. There are two tests that are high. One of them is RDW. Iron deficiency anemia has a high RDW. The other one is retic count. It's not a parameter, it's a test. So the retic count and the RDW are the two indicators that are elevated. Everything else on the red side is low, okay? So the only parameter is RDW, which is increased. Okay, true or false? The MCHC, normal value for MCHC is 32 to 36. And I did mention this. This is one of the things about troubleshooting to identify whether or not a CBC is acceptable. 32 to 36, you should tolerate. MCHC is 36, maybe 37, but usually 36 is what you should accept. If you get MCHCs in the 40s or 50s, I had mentioned this, that means there's an artifact present. So, and you can tell by if your MCHC is 42, you have, the first thing that you should look at is the MCHC. And I think I mentioned that when you're handed a CBC, one of the things, the first things that you look at to make sure that it's acceptable is to look at the MCHC. Okay. Next thing you can look at is MCVs and platelets. So I'm gonna get into that in depth in lecture number 10. But the first thing you should look at is the MCHC. If it's 42 or greater, or 38, 39, or greater than 36, you need to be suspicious. Okay. So 42, rule of 3, and then you can look at the H&H. With an MCHC of 42, knowing the calculation for MCHC, the rule of 3 is failed. Okay, the rule of 3 is failed. So it's not a reportable CBC. So that means there's an artifact there that needs to be addressed. Okay, iron deficiency anemia, I went over this countless numbers of times. Iron deficiency anemia and thalassemia hypomicro. Okay, it's hypochromic microcytic. IDA, iron deficiency anemia, is hypomicro. And I got a lot of normochromic macrocytic answers. And, you know, I said that several times. Iron deficiency anemia is a hypochromic microcytic anemia. Okay, so significant, the next question, significant target cells. Okay, if there's significant target cells, almost all of you got the correct diagnosis, and it's thalassemia. So what type of anemia is thalassemia? The two main ones that I discussed that are hypochromic microcytic are thalassemia and iron deficiency anemia. Okay, hypochromic microcytic, the two main ones I mentioned are iron deficiency anemia and thalassemia. Okay, again, I got normochromic macrocytic as a selection. So you need to pay attention to what I'm saying. And also too, the difference between iron deficiency anemia, because iron deficiency anemia does contain target cells. The way you can tell the difference between iron deficiency anemia and thalassemia is that the RDW for thalassemia is only moderately high. Iron deficiency anemia, the RDW is significantly high, okay? So significant target cells should have been a clue. RDW moderately high should have been a clue. And as soon as you see target cells, I told you T for targets, target cells, T for thalassemia, okay? And you know that thalassemia is hyperchromic microcytic. So most of you, which was interesting, most of you got thalassemia as your answer. So if you knew that what thalassemia was classified as, you should have got A. So thalassemia is hyperchromic microcytic. Okay, I talked about number 9, CBC parameter as used to determine acceptability. Again, for acceptability, the first thing you need to train your eyes to look at, the first thing that you need to train your eyes to look at, I'm telling you, is the MCHC. Okay, if you're handed a CBC, you need to look at this MCHC first. I'm not going to say, well, you can look around, look at the other things like WBC, RBC. No, MCHC. Look at the MCHC first to see if it's good. Next thing you do is look at the H&H, hemoglobin, hematocrit. Make sure that rule of threes passes. And then if the MCHC is elevated, another thing then you start looking at the MCV. Okay, maybe you put in a clump of cells like RBC agglutination or rouleau. Maybe you put rouleau through the machine, or you put a clot. You put a clot through the machine. That'll cause the MCHC to go high. Or you put platelet clumps. Platelets have a tendency to be sticky and they'll clump. And you can tell whether or not you have a platelet clumping. And I'll talk about that in lecture number 10. Okay, MCHC for acceptability. MCHC is make sure the rule of threes passes. And finally, okay, everybody got this correct on the homework. For a viral infection, what's the difference between a viral infection, bacterial infection, and leukemia? Anybody? How can you tell viral infection?
A viral infection has a low WBC.
Low WBC? Okay. Does everybody agree with that? Because I got answers like hemoglobin. Okay. Hemoglobin is not viral infection. I got answers like platelet. Platelet, platelet, I haven't had a discussion on platelet in any of the 4 lectures. That's coagulation and I talked about viral infection when I talked about WBCs. So low WBC is viral, moderately high WBCs is bacterial infection, and super high WBCs is leukemia. So I was kind of disappointed to see answers like hemoglobin and platelet on those selections. Okay, so that's quiz number 4. Do any you have any other more questions on these 2 quizzes? I know you probably had questions right after, but now that I sent you the answer keys, things really should be crystal clear. And you guys should have had said to yourselves, oh yeah, okay. Well, so one of the things because I know you guys are pretty smart, all of you are pretty bright, but also too, one of the things that I can tell is if you're not reading the PowerPoints or if you're not following the homework, because I'm competing with other classes like chemistry or serology. I mean, if you're gonna be studying your chemistry at the expense of not studying hematology, I can tell. Okay, so this stuff is pretty straightforward. When we get into the leukemias, it's gonna get progressively harder because right now we're doing red cells. After red cells, we're gonna be doing white blood cells. So, and then after white blood cells, we're gonna start getting into the leukemias. Okay, it's gonna get progressively hard. And then the final section will be coagulation. So when you're gonna be in the leukemia section and the coagulation section, You guys are gonna say, man, I wish we had the RBCs. This stuff is pretty straightforward. If you listen to me, and I think I'm pretty clear, and I always ask if any of you have questions. If you have any questions, you're only gonna hurt yourself if you don't ask, because I'll tell you, I'm willing to answer any questions, just stop me. For the quiz tomorrow on quiz number 5, it should be pretty straightforward from the lecture. Now, of course, you're going to say, well, that's easy for me to say because I made the quiz. But from the material, it's pretty straightforward. Know the terms, know the different types of cells, the diseases that they're associated with, the alternate names. Make sure you know the alternate names. How to tell the difference between schistocytes and bite cells. And there's going to be normal values where you're going to flag. You're going to flag an unmarked CBC, and you're going to indicate L or H, low or high. Okay. For the platelet count, somebody tell me the normal value for platelet count.
140 to 440.
Okay, 140 to 440. So if I give you 140 to 440, okay, and that's times 10 to the 3, correct? So it's times 10 to the 3. So if I give you 1,600, that's way over 140 to 440. So that means high. So I just want to make sure that the normal values for the platelet count is 140 to 440 times 10 to the 3, or times 1,000. So there's going to be a normal value question on tomorrow's quiz. Okay. And for the exam tomorrow, again, there shouldn't be any surprises. But make sure you read the questions thoroughly. Make sure you read the questions thoroughly, because some of the questions, they won't be straightforward. Okay, there are some, I'm not going to say trick questions, but make sure you read the questions thoroughly, that they make sense. Also, too, I know I talked about viral infection. Remember viral infection? One of the ways you can detect a viral infection is by looking at the WBC count. The WBC count is probably going to be low. It's going to be 1 or 2, maybe 3,000, okay? If it's that low, you need to suspect a viral infection. Another thing that you can detect a viral infection is by looking at the differential. Okay, so you know your normal values for differentials, right? First, the most numerous is segmented neutrophils, followed by lymphocytes, followed by monocytes, followed by eosinophils, and then followed by basophils. In a viral infection, there's this phenomenon called a reverse differential. So instead of the lymphocytes being the most numerous, instead of the neutrophils being the most numerous, the lymphocytes now are the most numerous. Okay, so you can have a lymphocyte in the 50s or 60s and the neutrophils in the 30s and 40s. So now it flipped. The lymphocytes are now the most numerous. Whenever you have that, the lymphocytes are greater than the neutrophils, then you have a possibility, you should suspect the possibility of a viral infection. And then couple that with your total white count. If your total white count is low, maybe like 1, 2, or 3,000, not as low as 1, but maybe 2 or 3,000, then that's going to be a possible viral infection. Okay. Also, too, I gave you a hint on tomorrow's exam. Make sure you know your normal values. Okay, make sure you know your normal values, because it's going to be on your exam. That's a given. Okay, I won't tell you which ones, but make sure you know your normal values. Are there any other questions?
Professor,
Yes.
In my email when I sent you the homework, I also had a comment about the links for the lecture recording. I wasn't able to rewatch lecture 5.
Number 5. Did anybody get lecture 5? Because I thought I had sent it. Nobody got it?
I got it.
Okay. You just clicked on YouTube and did a search. You want me to resend the link and then we'll follow up after lecture?
Yeah.
Okay. And who was that again?
Jazzy.
Okay, thanks, Jazzy. Anybody else having trouble with getting lecture number 5? Rudy? Okay. I'll send it out again to the whole class.
Thank you.
And I would appreciate it if you didn't get it by, I'm hoping to be done. If you didn't get it by 7:30, then email me, okay? If you didn't get it by 7:30, then I need to know. All right? Any other questions? Thanks for letting me know, because I need to know. Well, for those of you who are listening to my lectures again, is it helping? Does it help?
Yes.
Okay. All right. That's good to know, because I wouldn't want to be doing this and it's not, and it turns out that it's not helping you. Okay, moving forward. There are no other questions. We're gonna be talking about hemolytic anemia in lecture 6, and followed by aplastic anemia in lecture 7. All right, so hemolytic anemia. Hemolytic anemia.
Of the weather forecast. Now you have company in the doghouse.
Okay. So I'm just hearing some background noise. I thought that there was a question. So basically, anemias are based on RBC morphology. Hypochromic microcytic, as you know, the iron deficiency anemia and thalassemia. Those are the 2 main ones. Normochromic normocytic, that's type of anemia is found in chronic conditions like rheumatoid arthritis or tumors or endocrine disorders. And then the normochromic macrocytic. Those are the macrocytic, indicating big cells. So those are your megaloblastic anemias like vitamin B12 and folic acid deficiency, and also pernicious anemia. Those are the macrocytic anemias, or the megaloblastic. The term is megaloblastic anemias. And then there's a whole lecture that I'll be talking about megaloblastic anemias. Okay, so hypomicro, normochromic, normocytic, and the chronic conditions, and then the megaloblastics, the normochromic, macrocytic. So anything that's cytic refers to the size, and the chromic refers to the central pallor. So normal central pallor, and for the hypochromic, that means you got hypochromic cells. Remember the donut shaped cells. Okay, so anemia, the cell parameters that are used to identify anemia are the red cell parameters, which are hemoglobin, hematocrit, and red cells. You can use the RBC indices, but those are calculated. But the measured ones are the hemoglobin, hematocrit, and RBC. If you have an anemia, those 3 chances are will be decreased. Okay. And then I mentioned this last time that anemia is based on 2 conditions. Decreased production of red blood cells will cause anemia. Like, for example, iron deficiency anemia, you're decreasing the production of red blood cells, or increased destruction. And that's what I'm going to talk about now in hemolytic anemia, because you're destroying red blood cells. If you have a condition when you're actually destroying red blood cells, and there are situations where you actually do, then that would cause a hemolytic anemia. Hypomicro, hypochromic microcytic anemia. So the 2 main significant ones are iron deficiency anemia, sideroblastic, and thalassemia. So So far in almost every lecture, I've been mentioning this. Make sure you know hypo, micro, iron deficiency anemia, and thalassemia. Okay. Iron deficiency anemia is acquired and progressive, meaning that you're not born with iron deficiency anemia. If a baby is born and has iron deficiency anemia, it's not because of what they inherited genetically from the mother. If they're born, they're actually malnourished. That's the acquisition of the anemic state. When they're fed malnutrition, then that's an acquired condition. Iron deficiency anemia is acquired. And I talked about the 3 stages of iron deficiency anemia: iron depletion, iron deficient erythropoiesis, and then finally iron deficiency anemia. Okay, this type of anemia is the most common anemia in babies because they need their iron. These babies are growing, so they have a high demand for iron. Okay, it's also seen in pregnancy because of the iron requirements. Mother's now carrying a baby, so she needs to supplement the baby and herself with an increased iron requirement. And also too, women in childbearing years, if they're frequent blood donors or they have a high menstrual loss, then they can become iron deficient, okay? And also too in males, chronic blood loss, if they are GI bleeders, if they have a chronic condition where you have gastrointestinal bleed due to alcoholism, I'm not saying all men are alcoholics, but if they have gastrointestinal bleeds, that's a chronic blood loss, and that can lead to iron deficiency anemia. So those are conditions where iron deficiency anemia occurs. Laboratory findings of iron deficiency anemia, again, hypochromic microcytic. It's a hypomicrocytic anemia. And it's aniso and poic. It's not only aniso, you have to have anisocytosis and poikilocytosis. That's why it's red. The 2 go hand in hand. Decrease in hemoglobin hematocrit, your red cell marker, and RBC. RBC indices can also be low, and also iron levels, hence the name iron deficiency anemia. Okay, iron is low, H&H and RBCs are low. There are increased parameters in iron deficiency anemia, and that's RDW. RDW as a reflection of the amount of anisocytosis, and you guys know that. Increase in total iron binding capacity. I'll actually leave TIBC for Ms. Myrna to talk about TIBC and iron. And the retic count. The retic count is a reflection, and you know this, a reflection of bone marrow activity. So if you're iron deficient, you want your bone marrow to be active. It's hypercellular, meaning that the cells are constantly working to replace the iron that you're deficient in. So increase RDW and increase retic count. RDW for the aniso and retic count for increased bone marrow activity. Okay, so if you have increased retics on the peripheral blood, what would you see? What's a reflection? What represents reticulocytes on a peripheral blood smear?
If it's like purple, is that what you mean? Like what color?
That's the correct answer, but that's not the it's not the hematology 100 terminology I'd like to use. Polychromasia is what I want to hear.
Oh, okay.
So yeah, purple is the correct, but if I give you a choice, I'm not going to give you, well, if it's purple, if it's pink, or if it's got freckles. No, I'm not gonna use the layman's terminology. Polychromasia. If you see polychromasia, that means it's a good indication that you've got reticulocytes in the blood. Okay, polychromasia. Okay, in sideroblastic anemia, it's similar to iron deficiency anemia. Erythroid hyperplasia in the marrow. Again, you have a very active bone marrow. The erythroid precursors are active in the bone marrow because it's responding. Again, it's responding to iron loss. Okay, so here is a defect in hemoglobin synthesis. And that's common. Defect in hemoglobin synthesis is also common in other anemias. increase in serum and tissue iron. Indices are normal except for increase in RDW, just like iron deficiency anemia. But in this type of anemia, sideroblasts, which are found in the bone marrow, have a tendency to be ringed. So the sideroblasts, so this is what pathologists look for. You guys will never look at a bone marrow smear, but to diagnose this type of anemia, they would have to look at a bone marrow smear and identify sideroblasts. In this type of anemia, they will see ring sideroblasts. And what happens is iron accumulates in the mitochondria and it surrounds the nucleus of the sideroblast. So it makes it look like it's ringed. You got a ringed cell, okay? Ring sideroblasts, usually diagnosed by pathologists. Okay, then thalassemia, again, hyperchromic microcytic. Impaired rate of globin synthesis, decreased production of one of the globin chains. Okay, it causes excess in the other globin chains. So in alpha thalassemia, you have a defect in the alpha chain. Okay, so that makes it easy. Alpha thalassemia, defect in the alpha chain, but relatively an excess in the gamma and beta. Okay, so if you have an excess in gamma and beta, your other chains, you got three types of chains, remember that. You got alpha, gamma, and beta. In alpha thalassemia, you have a defect in the alpha chain. So as a result, you have an excess on the other genes, gamma and beta. On the other hand, in beta thalassemia, you have a defect in the beta chain, resulting in excess in the alpha chain. In beta thalassemia, there's no gamma chain, okay? So you have an excess in the alpha chain. All right, there's no gamma. Okay, make sure you know that. So alpha is a defect in alpha, beta is a defect in beta, alpha is excess gamma and beta is only excess in alpha. Okay, normochromic normocytic, it's a tricky one to see because if you look at a peripheral smear, most of the normal smears are normochromic normocytic. So you can't really tell. I mean, a patient can have something going on like a chronic condition like hepatitis or rheumatoid arthritis or a tumor. Those are not hematologic conditions where you can actually detect them because their red cells look normal. Okay, patient with kidney problems, renal problems, again, they will have normal looking cells, normal central pallor and normal size. And endocrine diseases like Graves' disease or diabetes or Hashimoto's disease, endocrine diseases, their cells will be normochromic and normocytic. The problem with these conditions that hematologically, they start off as normochromic normocytic, but they will evolve into a hypomicro type of anemia as the disease progresses. Okay, so the chronic disorders, you got rheumatoid arthritis, chronic infections, malignancies. These conditions can also decrease RBC life expectancy, which you all know that is the RBC life expectancy is 120 days. If you have these chronic conditions, then it can shorten that to maybe 100 or 90 days. I don't know how many, but that's probably why you're anemic, is that you have a slow blood loss because your RBC expectancy lifespan is it's not 120 days now, it's shorter. So you're still cranking out normal looking RBCs, but they're just dying faster. You're also not producing as much. You got decreased erythropoietin. Okay, so your bone marrow is slowing down and impaired iron metabolism. So you got suppression of erythropoiesis by cytokines. And I'm going to talk about cytokines when I talk about lymphocytes when we get into WBCs. So I won't get into cytokines at this point. So like I said, it starts off as normochromic normocytic, but as you can tell by the decreased life expectancy, the decreased erythropoietin, you can see how this could evolve into a hyperchromic microcytic. Okay, so patients with these chronic conditions, they can have diabetes in their 30s or 40s, but then when they get to 60, 70, they're going to become more anemic, and their anemia is going to appear to be hyperchromic and microcytic. And that's because of the chronic condition. Okay, so they start off as normochromic, normocytic, and then it'll evolve as the disease progresses and will become a hyperchromic microcytic anemia. Anemia of chronic disorders, normal to slightly decrease in the red cell markers, hemoglobin hematocrit, MCV, and MCHC. You'll see flagging, but you'll say, well, you know, it's not that bad. It's only 1 or 2 off out of the normal range. But that's what you'll see. Okay, you won't blink an eye. If you see a hematocrit or hemoglobin of 8 or 9 and a hematocrit in the 27s or in the 20s, now you're getting into significant anemia. Okay, and MCV, if you become microcytic, we're talking about 50s, MCV in the 50s. And MCHC, again, reserve the MCHC to troubleshoot acceptability of your samples. Acceptability of your samples. Okay, make sure it stays within 32 to 36. If you see an MCHC in the 40s or 50s, and I can give that to you on a quiz or whatever, then that means you're going to have to start troubleshooting. Okay, it's a troubleshooting indicator. Train your eyes to look at MCHC first. Lab findings: increase in RDW, serum iron, and free erythropoietin. I'll reserve the free erythropoietin and serum iron for chemistry, but you're going to get an increase in RDW. So like I said, it's starting to evolve into the hyperchromic microcytic, which is iron deficiency anemia. And that anemia, remember, has a high red cell distribution width. Okay. Chronic renal conditions, failure of the kidneys to produce erythropoietin. As you know, the kidneys is an extramedullary, it's not an extramedullary site, but it produces erythropoietin. Remember, the extramedullary sites are spleen, thymus, lymph nodes, and liver. Okay. Kidneys produce erythropoietin. It produces a hormone. It's a renal disease that leads to chemical imbalance or uremia. So if you see uremia, what type of cells, what type of red cell abnormality would you expect to see?
Echinocytes.
Say again.
Echinocytes.
Right. Echinocytes, Burr cells, or echinocytes. Okay, good. Okay, so renal problems, you'll see Burr cells or echinocytes if you have uremia. You could also have hemolysis due to mechanical trauma. So these cells can be pretty fragile, but I'm going to reserve mechanical trauma of red blood cells in hemolytic later on in this lecture. Okay, anemia of endocrine disorders. That's like thyroid problems, pituitary problems, adrenal problems, and gonads. The endocrine organs produces hormones for erythropoiesis. Okay, so if you have problems with these organs, and then you're not going to get erythropoiesis, and therefore you're not going to get RBC production. This is a normochromic normocytic. These cells look normal. The endocrine diseases. And the retic count is normal. So you wouldn't suspect there's anemia going on. And then finally, the macrocytic normochromic anemia. The macrocytic, again, those are big cells. Okay, whenever you see macrocytic, you're going to think megaloblastic anemia. And I do have a lecture reserved for just megaloblastic anemia. These are big red blood cells. So MCV is towards the upper limit, and it indicates a deficiency in B12, folate deficiency, and folic acid or folate deficiency, and also to pernicious anemia. B12 folate deficiencies cause impaired DNA synthesis, and that's why the cells are big. I'm not going to get into why, but because of the DNA synthesis between the cytoplasm and the nucleus, it causes the cells to be large. So what you'll see on the peripheral smear are oval macrocytes. These are large red blood cells. On the white blood cell side, what you'll see, and I'll talk about this when I talk about megaloblastic anemias and the WBCs, are hypersegmented neutrophils. You don't know what segmented neutrophils are, only that's what you see on the differential. But the number of lobes on the neutrophils is more than 5, so it's hypersegmentation. So all you know at this point are segmented neutrophils. In the megaloblastic anemias, you'll see hypersegmented neutrophils, where you're going to see more than 5 lobes to the neutrophils. Okay, and I'll be showing that to you in the megaloblastic anemia lecture. So, what are these cells?
Stomatocytes?
Correct. Those are stomatocytes. So, as I mentioned earlier, as hemolytic anemias, anemia classification is decreased production. Acute blood loss can cause anemia, and increased destruction. That's the one that causes hemolytic anemia. Anemia can be acute or chronic. The site of hemolysis may be predominantly intravascular or extracorpuscular. If I say intravascular, that means within the blood vessel, or extracorpuscular means outside the red cell. Okay, so outside the red blood cell, or within the blood vessel. So anemias that are due primarily to increased red cell destruction, that's the keyword, destruction, are hemolytic anemias. You got hemolysis, hemolyzed, okay? So hemolytic anemias, red cell destruction, make sure you know that. Okay, in hemolytic anemias, MCV and MCs are usually increased, but the reticulocytes, and it's in red, as you can tell, reticulocytes are increased to compensate for the red blood cell loss. So this is the bone marrow response, increase in RBC activities, and you'll see more reticulocytes or more polychromasia on the peripheral blood. Erythropoietin production is also increased. Also, too, bilirubin is increased, LDH is increased up to 10 times, because LDH is an enzyme found within the cell. If you got hemolysis, your LDH will be increased. And then haptoglobin is reduced or absent. I'll leave those last 3 tests to your chemistry class. Okay, now we're getting into the immune hemolytic anemias, okay? Immune hemolytic anemia. So this is kind of, because it also ties into immunology. So you got autoimmune hemolytic anemia. Autoimmune hemolytic anemia, okay? You got 2 types of autoimmune hemolytic anemia. You got warm autoimmune hemolytic anemia, and then you got cold autoimmune hemolytic anemia. The cold autoimmune hemolytic anemias are broken down into 2 main ones: cold agglutinin syndrome and paroxysmal cold hemoglobinuria, PCH. Okay, and then next you have alloimmune and alloimmune hemolytic anemia antibodies. Okay, so have you ever heard of these terms before? Autoimmune and alloimmune. Who has or has not? Well, you either have or have not. So tell me if you
have not.
Mostly have not.
Have not.
Yes, have not.
Okay. Autoimmune. How about autoimmune? Autoimmune.
Yes.
Okay.
Autoimmune, I have heard of it.
That means you have antibodies to yourself. You pretty much know that, right? Okay, so you have alloimmune. Alloimmune antibodies are antibodies that you create. I wish I had a whiteboard behind me, but alloimmune antibodies are antibodies you create after you're exposed to an antigen from outside of your body, okay, from another source. Okay, so for example, this is blood bank. For example, your red blood cells have a lot of antigens on the surface of your red blood cells. You know, you got D, you got Kel. Let me type this out because I want you to know what I'm saying. So on the surface of your red blood cell, it's covered with antigens, okay? And these antigens can attract antibodies. Okay, so if you have on the surface of your red blood cell, you have a whole bunch of antigens, like D antigen. D antigen, that's on the surface. Okay, the G antigen, or another antigen is Kel antigen. You'll learn this in blood bank. John's gonna be happy that I'm teaching you a little blood bank right now. Anyway, these are antigens. They're on the surface of your red blood cell, okay? So if you don't have these antigens, and it's possible that you don't have these antigens. Whoa. So it's possible that you don't have these antigens on your red blood cell. So everybody's red blood cell is different antigenically. You may have the D antigen. If you have the D antigen, then you're called Rh positive. You know your blood type, right? You're either Rh positive or Rh negative. If you're Rh positive, then you have the D antigen. If you're Rh negative, then you don't have the D antigen. Okay, so let's, for example, say that you don't have the Kel antigen on your red cell or the D antigen on your red cell. Okay, so you're deemed as Kel negative or Rh negative. Okay, so what happens is, when, you know, God forbid, if you need a transfusion for whatever reason, okay, you're receiving blood from the San Diego Blood Bank. Okay, so that unit of blood contains antigens as well, right? So that unit of blood can contain an Rh antigen. It could be Rh positive, or it contain the Kel antigen. Let's just say, let's use Kel. Okay, so your blood is Kel negative. You do not have the Kel antigen, correct? But you're going to get a unit of blood because you need blood to survive. You get this unit of blood, but it has Kel antigen. It's Kel positive, and you're Kel negative, right? So what happens? You'll get this Kel positive unit of blood. So what will happen is, and this is on the first transfusion, your body's going to see those red cells, and it's going to see the Kel antigen, okay? And your body's not going to be happy in the beginning, okay? So what will happen is, it sees these foreign antibodies. Again, this is you're developing alloantibodies. So what you're doing is, your body is being exposed to a unit of blood that has Kel antigen. When that happens, when Kel antigen is introduced to your Kel negative blood, your body's going to say, you're foreign to me, I don't like you, so I'm going to make anti-Kel antibodies. Now, when you do that, it's not going to be a severe reaction. Because your body's just going to produce the antibodies against Kel, okay? So now you have, now when you do an antibody screen, the person in the blood bank, the CLS, is gonna do an antibody screen, and they're now gonna detect that the patient has anti-Kel antibodies. So before the surgery, they did an antibody screen, and so the patient did not have any antibodies, no anti-Kel antibodies. But after they received the unit of blood that had Kel antigens, that patient actually developed antibodies to the KAL unit of blood because his blood reacted to the KAL antigen. So now you go from a negative antibody screen to now a positive antibody screen, and you have blood that has anti-KAL. Okay, that's now something that the blood bankers have to screen, and they have to screen that patient is identified as having anti-KAL antibodies. Because, say for example, the patient got into another car accident for whatever reason, God forbid, and then he needed blood again. Okay, if, for example, the blood banker did not see that the patient now has anti-KAL antibodies, and you give a unit of blood that has a KAL antigen, remember, the first exposure is just to develop the antibodies. Now, the patient is now armed with anti-KAL antibodies that is prepared to take on any KAL antigen that comes its way. So you give a unit of blood that has KAL antigen, and that patient has anti-KAL antibodies, you have a transfusion reaction, and that's not good. That's called a transfusion reaction. That's why the blood bankers, when they have a patient that needs to have blood, they need to do an antibody screen. So on this patient, they'll screen the patient and they'll say, oh, this patient has anti-KAL. What they'll do is that blood from the blood bank, they have to screen for blood that is KAL antigen negative. Okay. If the blood is KAL antigen negative, then that unit is safe to give to the patient. If it has the KAL antigen, that's the blood that you don't want to give to the patient. So the anti-KAL antibody that you develop against the first exposure of the KAL antigen, that's an allo antibody. Okay, it's an antibody that's developed from external antigenic source. Do you all understand? If you want me to re-explain it, I will. Anybody?
Yeah, can you explain it, but like shorter than what you explained it?
Okay, so I'm KAL negative. Okay, I'm KAL negative. I need blood. I get a unit of blood that has the KAL antigen. I'm KAL negative, so my antibody screen's negative. So big deal. So negative antibody screen. I take a unit of blood, and that unit of blood has the KAL antigen. So my body does not like the KAL antigen. So I'm gonna make antibodies to the KAL antigen. So now I have anti-KAL antibodies. I'm now prepared. I'm armed for the next time KAL shows up. So I now have a positive antibody screen, and I will have anti-KAL. So the next time, so that means that I develop the allo antibody anti-KAL. Okay. So the next time, and it's bad because the next time I get a unit of blood, they're going to have to screen for KAL negative units. That means units of blood that do not have the KAL antigen. Is that better? It's a little faster. So yeah, if I'm negative for a certain antigen, and I'm exposed to that antigen from an outside source, and I develop an antibody to that antigen, that's an allo antibody. It's an antibody developed due to exposure from an external source. Okay. Are we good on that? You can listen to the tape again if you're not. I'm recording this. Okay.
What would be another example of
allo? You want another one?
No, just what would be another scenario where that would be the same, outcome, where somebody was negative, or is it only in that?
Okay, that's my next example. It's going to be hemolytic disease of the newborn. Hemolytic disease of the newborn is another significant situation where the mother is Rh positive, so the mother has a D antigen, right? But Where is that? Okay. Okay, in hemolytic disease of the newborn. Okay, so the mothers are, the mother is Rh negative, okay? But the baby's Rh positive, which means that the dad has to be Rh positive. We're not going to get into any paternity scenarios, but the baby got his Rh antigen from the father. So the baby is Rh positive. So the mother has no protection against the baby's antigen. Okay, so because the baby now has a D antigen. So what'll happen is if the mother is Rh negative, so she's not protected, and let's say that she doesn't have the anti-D. What'll happen is if the mother delivers this Rh positive baby, the mother is going to develop antibodies against the baby, and that's not a good thing. And that's why you have a condition called erythroblastosis fetalis. It's not good for the baby because the mother's blood is attacking the baby. Okay, so since the mother's Rh negative, the mother is now making alloantibodies, anti-D alloantibodies, because of an external exposure to the D antigen from the baby. Okay, the baby is Rh positive or is D positive. So with the mother being Rh negative and the baby being Rh positive, having the D antigen, then the mother's blood is going to attack the baby. And it's not going to be good for the baby, and the baby will suffer from erythroblastosis fetalis, a lot of bad outcome with that. The baby will not survive, put it that way. Okay, so what'll happen is, and it's possible. I mean, just because the mother's Rh negative, that she can only marry Rh negative husbands. Well, that's not true. So she marries an Rh positive husband, and so the baby's going to be Rh positive. What they do is they give the mother what's called RhoGAM. Have any of you guys ever heard of RhoGAM before? Okay, RhoGAM is something that they give to Rh negative mothers. And what it does, it fakes out the mother into not making her own antibodies against the baby. So if the mother's Rh negative and they know that the father is Rh positive, they're going to give RhoGAM, which is artificial anti-D. So instead of the mother making her own anti-D against the baby, you're going to give the mother a small dose of RhoGAM, and it's going to fake the mother out saying, okay, there's an Rh positive baby coming. I'm going to make antibodies. Oh, wait, I don't have to because I just got a dose of RhoGAM. RhoGAM is D antigen. So if you have RhoGAM, and Rho is the Greek representing D, okay? And GAM is immunoglobulin. So it's D immunoglobulin. So you're going to give that to the mother. When you inject that into the mother, it tells the mother not to make her own anti-D antibodies. It's the mother's anti-D antibodies that will kill the baby, resulting in erythroblastosis fetalis. So when you give the RhoGAM, then the mother will not make antibodies against the baby, and the baby will survive. You see that? You understand that? Are you guys good with that? Alloantibodies. So are we kind of clear on alloantibodies now? Yes?
Good.
So alloimmune hemolytic anemia, the antibodies will occur as a result of antigenic stimulation, antigenic from an outside source. The antibody is called an alloantibody. So alloimmune hemolytic anemia, again, allo occurs with blood transfusions. And I use the example of the KEL and the patient needing blood that has the KEL antigen. So what happens is antibodies in the patient who needs the blood will attack the transfused blood. Okay. Cold agglutinin syndrome. Now we're getting into autoimmune hemolytic anemia. This is where you have antibodies against yourself. In cold agglutinin hemolytic anemia, the patients are usually 50 years of age or older. And this condition takes place in patients with CLL, chronic lymphocytic leukemia, lymphoma, infection, and malignancy. And it's a cold autoantibody. And the type of antibody is an IgM, and it's an anti-I antibody. It's active. So these antibodies are active at colder temperatures. Another one is, so what happens is when it comes to room temperature, when the antibody comes to room temperature, then like when it circulates into the core of your body, then complement activates the red blood cells, and then you get hemolysis of the red blood cells, okay? And that's what happens. Another good example of that is, I think another example is coming up. Okay, Raynaud's phenomenon. Raynaud's phenomenon is another cold agglutinin syndrome. It's another cold agglutinin syndrome where there's cold and it's painful. And it's painful. You got blue fingertips and you have blue toes. So that's on the periphery, on your toes and fingertips on the periphery. So cold weather activates this antibody. And what happens is the cold antibody agglutinates and fixes complement at the extremities. It fixes complement to the red blood cells at the extremities. And what happens is in the patient's circulation, when the blood travels to the core of your body at 37 degrees, what happens is the cold agglutinin will elute off the red blood cell. It'll come off of the red blood cell, the cold agglutinin, and it leaves complement behind. And then also too in the core of your body, with that free complement, it's now gonna bind to the red blood cells and activate the complement cascade. And when it does that, when the complement cascade is activated, it's gonna lead to red cell hemolysis. So just remember, when you activate the end product of the complement cascade is cell hemolysis. And that's what happens in cold agglutinin syndrome. And that's why creates hemolytic anemia. So it starts off in the extremities. The cold antibody will bind the complement at the extremities, and then it's fine. But when it circulates to the core of the body at 37 degrees, the cold agglutinin elutes off, releasing the complement, and the complement will now bind the red blood cells and activating the complement cascade, and that's going to lead to hemolysis. And that's a cold agglutinin syndrome. Another one is paroxysmal cold hemoglobinuria. This is another cold autoimmune hemolytic anemia. And this one occurs in children. And it's in children that have chickenpox, measles, mumps, and IM is infectious mononucleosis. Okay, this type of antibody is a cold reacting antibody. It's IgG, and it's an autoantibody, okay? And the antibody is called a autohemolysin, and it's also called Doneth-Landsteiner antibody. So it has three names. It's cold reactant IgG, autohemolysin, but it's the Doneth-Landsteiner antibody. Okay, so this autohemolysin or Doneth-Landsteiner will bind to the P antigen on the red blood cell. Remember, the red blood cell has a whole bunch of antigens on the surface of the red blood cell. If you happen to have the P antigen, then that's what the autohemolysin will bind to, okay? And once it's bound, then again with the blood circulation at 37 degrees, the autohemolysin fixes complement and it leads to hemolysis. So it circulates, and then once it gets to the core again at 37 degrees, the autohemolysin will fix complement and lead to hemolysis. So that creates a hemolytic anemia. Okay, Hemolytic anemia, all those, remember those abnormal RBCs, spherocytes, that's found in hemolytic anemia, elliptocytes, hemolytic anemia, stomatocytes. Those are all, those three will result in hemolytic anemias. Then the fourth one is paroxysmal cold hemoglobinuria, and that's another one that I haven't talked about. But hereditary spherocytosis, like I said, the MCHC can be legally elevated, upper limits of 36, but not too much more, okay? 37 is acceptable, but if you see spherocytes on the smear, then that's the reason why you have a high MCHC, okay? Spherocytes are abundant on the smear. I wish I had one in my collection where there's a whole bunch of spherocytes. The test to detect hereditary spherocytosis is the osmotic fragility test. The osmotic fragility test is where you draw a tube of blood. I don't know if you, Xavier will do it in class. You draw a tube of blood, you wait, and I think you wait for like half an hour or for extended period of time. And then after a while, you centrifuge it. And what you look for in the plasma or the serum, I think it's plasma, you look for hemolysis. If the specimen looks hemolyzed, then that's a positive test. It's a really easy test to do, the osmotic fragility test, okay? Because spherocytes have a tendency to burst, okay? They have a tendency to burst. So if you just let it sit there and then it'll naturally burst, it's gonna release hemoglobin and your plasma is gonna become hemolyzed. Okay, so remember, spherocytes are on the verge. You've got it's maxed out in terms of the hemoglobin contents within the cell. It's maxed out. So if you give it any kind of stress, it's going to burst, and because these cells are really fragile. So the osmotic fragility test, if it's positive, then it's for hereditary spherocytosis. Autohemolysis test is positive in 48 hours. So that's how long you can actually run the test. If you can spin it after a short while before you go home, but you actually keep it for 2 days. And if you see hemolysis, then that's a positive osmotic fragility test. Those are the spherocytes right there. Small microcytic cells, no central pallor. No central pallor. They're the dark ones and they're the microcytic ones, okay? So this one probably is hereditary spherocytosis. Hereditary elliptocytosis. Elliptocytes or ovalocytes are the abundant cell type on the smear. Most of these patients are asymptomatic and they'll develop, some of them will develop a mild to moderate hemolytic anemia. And those are the elliptocytes and the ovalocytes there. You should know that by now. And then stomatocytes. You know what they look like? Biconcave disc. Okay, so for shapes, stomatocytes are bowl-shaped, okay? Red blood cells are what shape are the normal red blood cells?
Biconcave.
Right, and what about target cells? You remember what the target cells shape is?
It's target cell.
Bell shape.
That's the bell shape, okay? So target cells are bell-shaped, stomatocytes are bowl-shaped, and normal red blood cells are biconcave disc. Stomatocytes right there, pretty obvious, pretty easy. Okay, and then that fourth hemolytic anemia is paroxysmal cold, paroxysmal nocturnal hemoglobinuria. And this type of hemolytic anemia is found in children. PNH occurs in young adults, and it also involves complement, okay? And it occurs in children, and what happens is their cells lyse at night and when they're asleep, okay? So the complement interacts with each other to bring about complement-dependent cell lysis. So that complement cascade is activated. The red cells are sensitive to complement, so when they bind to complement, the cascade is activated, resulting in cell lysis. And it occurs at night and it occurs when they're sleeping. So this is paroxysmal cold hemoglobinuria, or PNH. Okay, PNH. All right, so PNH. Make sure you know how to test for PNH, or paroxysmal nocturnal hemoglobinuria. So to screen for it, and make sure you understand it's screening. To screen for PNH, you have to do the sucrose hemolysis test. That's where you take the patient's blood and you add it to sucrose, incubate it at 37 degrees for half an hour, and you look for hemolysis. Okay, so you're mixing it with sucrose. This is called the sucrose hemolysis test. I guess you can say S for screening, S for sucrose. Okay, sucrose hemolysis test is the screening test. So again, add sucrose to the whole blood, incubate it for half an hour at 37 degrees, and you look for hemolysis. If you do see hemolysis, it's positive for PNH. But do you call it PNH at this point?
No.
Who said something? It's okay to guess. I mean, you guys shouldn't be afraid to guess.
Me.
No.
No. The answer is no, because this is a screening test. You can't have a definitive diagnosis on a screen. Okay. So the screen is positive for PNH. Okay. So when you have a screen that's positive, you have to go do a confirmation test. And the confirmation test is the HAMS test, which is an acidified serum test. Okay. So on the HAMS test, it uses hydrochloric acid, 0.2 normal HCl. Okay. So in this test, you're going to use the patient's blood. You're going to mix it with hydrochloric acid. And then if you continue to see hemolysis, then now it's confirmed. Okay, so PNH is confirmed with the HAMS test, and PNH is screened with the sucrose hemolysis test. All right, so we got screening and confirmation on sucrose hemolysis test and the HAMS test. Okay, and that's for PNH. All right, hemolytic anemia as a result of non-immune reasons. Okay, so you can have hemolytic anemia caused by malaria infection, and that's obvious because the malaria parasite will invade the red blood cells, and what will it do? It's going to burst all the red blood cells, resulting in hemolytic anemia. And same thing with Babesia. Babesia is intracellular. It's going to infect the red blood cells, causing them to burst, resulting in a hemolytic anemia. So malaria and Babesia are intracellular within the red blood cell infection. Extracellular infection, that means outside the red blood cell, you can have Bartonella, which is a bacteria that I'll talk about next semester, and Clostridium perfringens. Those cause hemolytic anemia. Those are bacteria that can cause hemolytic anemia outside of the red blood cell. Okay, so you got intracellular and extracellular. And then other reasons for hemolytic anemia: marching. Okay, you got mechanical destruction, chemical and physical agents, and osmotic effects. So mechanical destruction, marching or march hemoglobinuria, and that's soldiers, the recruits, when they go to their boot camp and they do nothing but marching, march. They're actually on the heels of their feet, destroying red blood cells. They march a lot. So some of the recruits can actually become anemic, and that's they're actually suffering from hemolytic anemia because of all the marching, all the red blood cells that they're smashing because of the marching of their feet. Okay, so that's march hemoglobinuria. Traumatic cardiac hemolytic anemia, where the heart valve is so intense that it's actually destroying the red blood cells. And microangiopathic hemolytic, when they're destroyed going through the capillaries or your blood vessels, destroying the red blood cells. So there's three ways you can mechanically destroy red blood cells: by marching, traumatic cardiac and microangiopathic. Chemicals and physical agents can cause hemolytic anemia, can destroy red blood cells. Oxidant hemolysis, as I talked about in a G6PD deficiency, or non-oxidant hemolysis, where you have arsenic exposure, where you get acid plus metals and yielding arsenic gas. If you breathe the gas, and that can cause hemolytic anemia. And then lead poisoning with children who consume those paint chips in the homes. So whenever you see basophils, it's probably lead poisoning that can cause hemolytic anemia. So lead, arsenic, and oxidant hemolysis are chemical and physical agents that will cause hemolytic anemia. And finally, osmotic effects, burns and drowning. If you suffered burns or if you were involved in drowning, that can cause your red blood cells to burst. Osmotic effects, okay? Osmotic effects from burns and drowning. So those are 3 non-immune hemolytic anemias. And then I already talked about G6PD deficiency. And G6PD is the only source of NADPH. NADPH defends cells against oxidant stress. Okay, so that's the importance of G6PD. Patients who have this deficiency are usually asymptomatic. You can't tell. Okay, you can't tell. However, if you're G6PD deficient, fortunately, there is a plus, there's a bright side to this, that you're resistant to infection from Plasmodium falciparum malaria. So if you don't have G6PD, then lucky you, you will not get a Plasmodium falciparum malaria. The drugs that can cause you to have hemolytic anemia are the sulfa drugs, antibiotics, analgesics, naphthalene, and antimalarial drugs. Those, if you have G6PD, can cause you to have hemolytic anemia. Okay. All right. Are there any questions? Any questions? All right. I'm going to send you the link to this lecture, and hopefully you can listen to it again, especially on the area of alloantibody production. It's really important for you to know that because you'll get that again when you get into blood bank. All right.